Thank you, and good morning. It wasn't long ago that you would not have heard the word urgent and the word stroke in the same sentence. And indeed, within the working life of some of the people in the room, very few patients would have come into any contact with organised stroke care or evidence-based care around stroke. We now have very strong evidence, particularly evidence that's changed just in the last 12 months, that we can cure some strokes in a hyperacute setting in a time-critical way. But to put those systems in place doesn't stop at the door of the hospital. These are statewide systems, they're 24/7, and we'll be walking through the journey of how we put these things in place at Prince Alfred and across New South Wales. But we might begin to show you what we do with Marie's story, which we have a video of one of our patients who was on a Jetstar flight flying between Hawaii and Melbourne. And Marie began to get some symptoms, which fortunately one of her nurse travel companions noticed were those of stroke.
Jetstar 2, the wind 030 degrees, 12 knots, crosswind 12, clear to land.
Marie, Sally and myself were on a flight back from Honolulu to Melbourne.
I can remember Debbie telling me the lower right side of my face had drooped.
Marie's right eye become very bloodshot, so the cerebral pressure was very great, so I knew that we had to do something.
I said to the cabin staff, look, my friend I think has had a stroke.
We just tried to assist her as much as we could by giving her oxygen bottle and blankets and everything.
Will she make it through this? It didn't look good.
We started to plan to see where we were going to go. I knew from just my reading and talking to people before that time was really critical with the stroke victim. We then upgraded our flight to an emergency with air traffic and they gave us priority into Sydney.
Clear to land, runway 34 left, 10
We had her down and in RPA within an hour 30. I mean, that is amazing.
We got the stroke page to let us know that someone was coming in with a severe stroke.
Time is brain, so the quicker people get to hospital, the better it is for their outcomes. So we tell people to look for FAST, so someone who's got a facial weakness, an arm weakness or a speech disturbance. So we tell anyone who has one or all of those signs to call an ambulance quickly and they'll take you to a stroke hospital.
We made the decision to give you the medicine to try to dissolve the clot. We take another little small device up and we put that next to the blocked vessel in the clot, apply a bit of suction through a little tube and take it out.
I think we've got something major to offer. We've got a 24/7 service. The clot busting stuff, the alteplase medication and the use of the clot retrieval makes a substantial difference in reducing disability in a group of strokes that don't do well with what had been the existing treatment. And that's very good, really. We've been very happy with the improvement that you've had. She's like someone who's come in with a small stroke in the first place, but that's not how she arrived. She arrived with a big stroke and it was turned around by the whole process of care.
Daunting, I thought. The last time I can remember was getting ripped off a plane in a wheelchair.
Ladies and gentlemen, welcome to Hobart, where the current time is 4 p.m.
To see her actually walk through the doors is absolutely amazing. You know, deep down I was expecting her to probably come through in a wheelchair or going to get her and coming back home on a boat. Unbelievable. Today it's probably the best feeling I've had for a long, long time.
I've enjoyed talking to the specialist because I've learned a lot more about stroke, but the highlight for me was meeting Marie and the two girls. The result is remarkable.
She got the all clear with the MRI. She's pretty strong, Marie, so yeah, she doesn't really surprise me that much.
My son reckons I'll live to 100.
Yeah, I have no doubt.
The patient themselves is an illustration of what's called a large vessel occlusion, an ischemic stroke, which is the majority of strokes that people have in New South Wales. If you look at this artery here on an angiogram, you can see that it's not there and the one on the other side is there. And with that, the person within seconds will start to lose clinical function and take on the appearances of a stroke. It's only in relatively recent times that we've had an opportunity to reperfuse that circulation, to clot bust, and to avoid what might otherwise have been a large stroke, such as the one that you can see here. That colour mapping is very modern and advanced imaging. And on your right-hand side, you can see a brain scan, and the red section is the part of the brain which we expect will be a completed stroke. The area around it is known as a penumbra, and that penumbra is an area where we can salvage the stroke and make it smaller. Within the matter of hours, and we only have hours available to us, we can actually turn a potentially fatal and certainly seriously disabling stroke into a much milder stroke and sometimes cure it entirely. So what is the burden of stroke in New South Wales? There are 11,000 strokes in New South Wales each year. About 700,000 to 800,000 of those are due to the blocked artery that I'd illustrated on the angiogram. What's the cost of this? A few years ago it was estimated that stroke was costing Australia about $5 billion a year. Within New South Wales, it's a few $100s a year for the assessment and management of acute stroke and the handling of the disability that may follow it, and the federal government faces a similar bill. It's what's called a high-cost DRG, a diagnostic-related group. And for the sort of strokes that we're particularly interested in treating and presenting today, those patients can easily cost $86 million in the New South Wales health system per annum. And what we see here is the evidence that has changed over time. You'll see a stairway there of the evidence that's emerged really since towards the end of the last century. If you provide an acute stroke unit with organised multidisciplinary care, you can reduce the mortality of your patients by about 30%. You also reduce their disability, you improve their discharge destination. 30% of patients are much more likely to get home. More recently again, intravenous drugs have been found to be able to open the arteries up, but only in very selected people and in a very limited time span of about 4.5 hours. Imagine, if you will, you're sitting in a small town in Western New South Wales and you need to access the specialty services to deliver that care. Nonetheless, that sort of care does provide about a 30% reduction in your disability. But what we're mostly talking about today is retrieving clots from arteries, directly, physically, mechanically taking a clot out. For a number of years people had been trying it, but it wasn't until 2015 that they successfully showed that you could do this in patients under 6 hours, highly selected, but it made an enormous difference to patient outcomes. An additional 30% benefit, and to those patients who were most likely to do badly with stroke, those with a large vessel occlusion. Now, 2015 was not long ago, and even more recently, towards the end of 2017, the beginning of this year, we've now discovered that we can do this out to 24 hours. So an acute emergent stroke is now a 24-hour process where we can make an enormous difference. But these are very resource intense. We need to move people around New South Wales. There are only 2 24/7 services currently operating in Sydney, and we serve the whole of the state. And we went from a standing start. No one thought clot retrieval was going to work. They've been trying for 10 or 15 years before the technology and experience allowed it to demonstrate its benefit. So what we now have in New South Wales and the world in general is level 1 evidence, the highest quality of evidence you can have, that if you have an acute stroke, you need to be on a stroke unit. If you're under 4.5 hours and you have the appropriate imaging and clinical assessment, you should be given an intravenous drug that stands a halfway reasonable chance of dissolving that clot and a 30% chance of reducing your disability. But the infrastructure to build the next 2 bits, pulling a clot out under 6 hours, more recently under 24 hours, is an enormous build. And the build doesn't stop at the door of our hospital and involves an enormous number of partnerships and an enormous team effort. Some of our rosters of nurses, for example, in radiology and the radiologists themselves, we have 30 people supporting the rosters to provide this emergent service. So what's the benefit? Not everyone is going to benefit. So in this figure, we have the impact of giving the intravenous drug. The intravenous drug doesn't work so well on those people with large clots. It's meant to dissolve something, A larger clot does not easily dissolve. But then, if we can make it available, and it is hard to make this available across New South Wales, you get, again, a 30% benefit. But most of the people who undergo the treatment are not going to realise this and will be left with a large stroke. But very few patients, shown in red, are going to suffer a mishap as a result of the treatment, which is reassuring. So what have we got across New South Wales? There's about 180 places that provide emergency care in New South Wales. There's only about 39 stroke units in New South Wales distributed. There's 23 places that undertake to provide a 24-hour service to give the intravenous medication to clot bust. John Hunter Hospital provides a 24/7 service for their region, and there are only 2 services operating 24/7 in New South Wales, and ours has only had a go live since April. It's been a massive build between evidence in 2015 to have a go live at the beginning of April, which can serve people across the whole state. Now, there are many steps in this. From the point of somebody having a weak face, a weak arm, difficulty with speech, and making a 000 call, or as 30% of people will do, privately turn up in their own transport. We have ambulance dispatchers now that recognise stroke symptoms, try and make sure the right team gets to the right place in the right time. But you don't want them necessarily taking the patient who's having a stroke to a hospital which provides no organised stroke care. So this is a complex process of bypass. The ambulance drivers themselves do a stroke test on the patients, and depending on the timing of the onset of their stroke, will bypass hospitals to get them to the right place. So this has changed even in the next few months. Instead of bypassing people under 4.5 hours, we'll shortly be doing it under 24 hours. They phone ahead on a bat phone, and the hospital readies itself for the presentation of the patient. Remembering this is being done at all hours. Sometimes the team members are not actually in the hospital at that time, although we keep a standing registrar. So they present to a hospital, to an acute thrombolytic centre, and now what they need when they get there is not just the standard brain scan that they were doing 12 to 18 months ago, but a new brain scan that gives you those images you see up there, which tells you how much brain you can salvage with a procedure. So a patient will go, for example, to Gosford, as we'll present. They'll get their thrombolysis, having been taken lights and sirens past a smaller hospital, and then Gosford will ring us on a 1300 ECR number, which, if I don't pick it up or one of my colleagues, actually goes through to Teresa Anderson, our Chief Executive, which is a very big incentive to pick up the phone. It only took a week for me to miss one. Haven't done it since. And they arranged for them to come to Prince Alfred Hospital. Now, this build occupied lots of people, including Teresa very directly, and her chequebook as well, through 2015 to ensure that we had the capacity, 24 hours a day, to actually pull clots out. That meant recruiting new people, putting in new equipment, and very importantly, putting in new processes. You can actually measure the loss of patient function according to delay in treatment in 5-minute lots. So for every 5 minutes you lose through an unintended delay, the patient potentially has a worse outcome. As I say, urgent wasn't the word you used in the same sentence of stroke, and we're talking about changing a whole culture and attitude to the way stroke is managed. So we know the drive times from everywhere in New South Wales to the local centre. We have a pizza application, as I think David calls it, which means that we can look and see where our ambulances are coming from and what their estimated time of arrival is. But we've had to improve our imaging access. Even now, we still have issues looking at other people's scans, but we are working with our referrers across the state to try and improve that deployment, but also our referral processes. I think some of our documents have actually had to change with changing evidence. So often we're in version 9 of some of our own pathways. They're being continually revised. We work with our referrers very closely. We visit their sites, we look at how they manage their patients in the emergency department, how they transfer their patients, and how they image them. And this is complicated. This is how you select patients to put in an air ambulance, in a helicopter, or in the back of an ambulance to come to us. You need good quality imaging, you need it deployed, you need people who can read it. You need people who can assess the patients in detail so that we know that we're sending the right patient to the right place and, importantly, in the right time to do the right treatment. New equipment, a new angiogram suite, new CT imaging equipment, a new ECR simulator, and if any of you fancy yourself as an interventional radiologist, we have a simulator over there that you can practice on. There's a fellowship available for next year. And staff enhancements. Huge numbers of staff are required, new allied health personnel to look after what's been an enormous increase in the number of strokes that come to us. New neuroradiologists such as David, me, additional nursing staff, additional staff specialists in neurology, anaesthetics. This makes a Formula One pit stop look like small beer. The reality is we often have 8 people around the patient as they come through the door. And I'll just hand over to David. David is one of our interventionalists who provides service at all hours of the day and night. And he'll show you how we measure our strokes, what the imaging really means, and how we get the clots out.
I'm just going to quickly talk about some of the acronyms you've seen in the talk so far. So we talk about the NIS score, which is a score that we apply when a patient comes to the hospital. We do some examination, a very abbreviated neurological examination to determine the severity of their stroke. So the treatment, especially clot retrieval, is really reserved for patients with large stroke. If you're having a very mild stroke, it's hard to justify some of the risks of the procedure if the stroke's very mild. The second acronym, the MRS score, is a measure of someone's function. So most people in this room would be a 0, so no symptoms at all, everyone's healthy and normal. Some people might require a little bit of assistance with daily activities. It's an interesting score because a 1's a lot better than a 2, but if you look at this, maybe a 6 is actually better than a 5. So 6 is deceased and a 5 is severely incapacitated. So we offer clot retrieval to patients with an MRS of 0, 1 or 2. We don't offer it if their premorbid function is very severe. And what's a large vessel occlusion? Large is a relative term. These vessels we're talking about are only about 4 millimetres to 2 millimetres diameter, but compared to the other vessels in the head, they're the large vessels. You have 2 large vessels at the front called the carotid arteries and 2 at the back called the vertebral arteries. The ones that we're trying to unblock are the carotid arteries, the MCA, which supplies half of the brain, and the basilar artery at the back of the brain. So I could talk for an hour about how it's done. I love talking about it, but I haven't got that much time. We've got a simulator in our booth, so if you'd like to come and talk to me, you can even have a little go and have a practice. We get the imaging done with the CT scan as quickly as possible, so we do a non-contrast, a CT angiogram and a CT perfusion study. We're selecting the right patients. If it's done elsewhere, there's a phone call to us on the hotline. We get the patient as quickly as possible to the hospital. Everyone's ready in the angio suite to accept the patient. The patient can go off to sleep for the procedure. Sometimes it's done with the patient under some mild sedation. We access the arterial system from the artery at the top of the thigh. We take our small catheters through the arterial system and try to unblock the artery. At the end of the procedure, you're left with a small cut in the skin, about 2-3 millimetres at the top of the thigh. It doesn't even need a staple or a suture, and hopefully everything's gone well. So we do an angiogram first, which is when we've got a little tube in the carotid artery in the neck, we give an injection of the dye, and that shows us where the blockage is. And then we have a series of little devices that we take up, little tubes about 1 or 2 millimetres diameter, tiny little wires, and we take that up to the area of the occlusion and use a device to open the artery. This is called a stentriever, so it's a mashup of 2 words, stent and retriever, sort of like Brangelina, but that's history now, I guess. Now this is the device that someone worked for this procedure in about 2006, and since then we did research, and all that research was published in 2015. The device costs about $6,000. Okay, now it looks like you could knock it together with a bit of chicken wire and stuff, but it's actually a very sophisticated device. It's made of memory wire. I used to watch Beyond 2000 when I was a kid in Tasmania, and they had the memory wire that they dipped into the hot water and came out as a shape. So this is very sophisticated stuff. It's about $6,000 worth. People in this room would know how much a day in hospital costs and a day of rehab, so when you can minimise that amount of time for the patient, it's actually a cost-effective device, and the procedure is very cost-effective. This just shows a picture that I've drawn with a stent across the clot, and we take it out and hopefully it comes out in one piece. So we have a measure to show how well we've opened the artery. We're looking for an artery that's more than 50% open. Sometimes it's like pulling a cork out of a wine bottle, and a small amount of the cork will go off somewhere and we won't be able to get it out, but hopefully we can get at least 50% of the artery open. That's all really good to have a nice looking angiogram, but what we're really interested in is the patient outcome. So this is a slide from our bi-weekly reperfusion audit meeting. So every case we do, we go from when the stroke was the team was activated, go through our process and see how we're going. So this is a 69-year-old patient from Gosford that was transferred down to RPA for treatment. Premorbidly very well, a couple of risk factors for stroke, the main one being atrial fibrillation, so irregular heartbeat, a little clot's formed in the heart and shot off towards the vessel in the brain. This is a non-contrast CT head showing that there's no hemorrhage, which means the patient could have the clot-busting medicine in Gosford. And this is a scan. The coloured map shows the red area is the area of the brain that is already damaged and won't recover. The green area is the bit that's blood supply is reduced but can still be reperfused. And that, you can see there the large vessel occlusion, the right MCA. So these are the pictures before and after clot retrieval. So the picture on the left of the screen is the angiogram before we open the artery, and the one on the right, you can see a lot more branches coming around laterally. Here's another picture of that. And the patient did very well. So a stroke score of 17 when they're at Gosford, and that was reduced to a stroke score of 2. So we've turned a very large stroke into a very mild stroke. Thank you.
Okay, so we're running out of time, so I'll try and be really quick. So now we look at the outcomes all the time and we're constantly reviewing our data. So the first thing we did, we changed our staffing profile, and we've got people working after hours now for the neurology team, because as you can see, about 65% of these cases are transferred in after hours, so the bulk of it's happening after the time. We are constantly looking at our numbers, and as you can see, we've had a big increase. As John said, we went live in April of last year, and we did 121 cases last year compared to 38 the year before, and we've already done almost 80 for this year already. So it is going up astronomically, and the places that they're coming from, the furthest away we've taken is Dubbo, but we do tend to cover the North Coast regularly as well, so the patients are coming from everywhere. Part of our enhancement, we're looking at what we're doing in terms of the stroke guidelines and how our care actually relates to the guidelines. And you can see we have gone from about 60% for most of the guidelines and how we're doing our care to about 90% for most things now. So we're getting better access to allied health, we're doing better with secondary prevention, and our stroke unit care, we've got 95% of strokes going through the stroke unit now, which is pretty astronomical compared to the rest of the state. Our door-to-needle times are another big part of our thrombolysis. As John said, the benchmark is about 20% for patients who should be thrombolysed. We sit at about 25% at RPA, so we are one of the better performing hospitals. And our number of cases that we thrombolise is going up every year, and our door-to-needle time is slowly going down. So we're sitting below the international KPI of 60 minutes, and our median time is currently about 50 minutes at the moment. We're also measuring our recanalisation times and our recanalisation rates. We are looking at, I can't even see that. So we are looking at our numbers. Sorry, it's really hard to see up here. So we're looking at our numbers in terms of where they're all being discharged to, and you can see about 60% of our ECR cases are discharged to other facilities, which has a big flow-on effect to the rest of the hospital in terms of admissions, because the numbers are going up quite astronomically, and 20% of all of our stroke cases are now ECR patients. We have compared our outcome data to the 5 big RCTs that were done in 2005. They did a Hermes meta-analysis, and as you can see, our recanalisation rates were a lot higher. So the Hermes data was about 71% had a recanalisation of TICI2 or TICI2B or 3. Ours is currently sitting at around the 89%, so the boys are doing a very good job. But the best part for us is our MRS that David was talking about, people who are functionally independent after their stroke. We have about 32% of patients are functionally independent after they have clot retrieval, compared to the 21% that was mentioned in the Hermes. That's me. We'll quickly let John go, and you've got 1 minute.
Thank you, Kylie. You heard 65% of our patients actually leave our facility and leave our area health service. We need to work out if our systems work. We need to work out when we've done something wrong and what we need to make better. We've got a new stroke observatory which actually allows us to follow the patient around the state. We can use routinely collected data from other hospitals, match it up with what we did at Prince Alfred at the bedside, and see what we need to make better. Every step on that animation looked quite crude compared to our predecessors of that ambulance, and those phone calls can be refined. How quickly someone comes through the emergency department at Dubbo, how quickly they scan them, how quickly they call us, how easy it is to call us, how quickly we respond. Each and every one of those steps is being revised. Not a single document of ours has stayed the same for more than a couple of months as we try and dig down to what makes a better, quicker service. Marie, from the time she hit the door at Prince Alfred Hospital to getting her dose of thrombolysis, took 16 minutes, including a brain scan and a complete assessment. She was already having her clot removed at 34 minutes after she arrived. These are unheard of speeds internationally. But we also wanted to close the loop. There's the acute phase of the stroke, the potentially curative, the supportive in the stroke units. But the other thing is preventing stroke. So as part of being a new comprehensive service, we've expanded our ambulant care to manage transient ischemic attack, prevent further strokes, and to manage complex patients. These include our young stroke clinic and perioperative assessments for stroke patients. Basically, we're taking patients from the time that they have their stroke through to the rest of their life to make sure we don't see them again in an acute setting. This is not a Prince Alfred service. We've funded it, we staff the removal of the clots, but this is a true statewide service. We're in close contact with ambulance, the health pillars, the LHDs that are our referrers. It's an enormous partnership, and I'm very proud of everyone that we've worked with. We've not hit any obstruction at any point in this. People have been devoted to this process and put enormous amounts of work in. So what have we done? We're admitting 35% more patients than we did even months before. We're one of the fastest services at pulling clots out that anyone's going to find anywhere. We've got an extensive investment, but we've also been getting a return on that investment. We're expecting in the next week or two to have done our 200th case since the beginning of 2017. We're expecting that this year we'll have done 193 cases. This will make us amongst the biggest 2 or 3 sites in the country, and we've only been running for about 14 or 15 months. And our performance outcomes match those of any international site. And as I say, we've closed the loop. It's a comprehensive service, it's a complex service, it's a fast service. And to have done this, I sat in meetings with Teresa before I started my job where she told me everything would be fine. I looked at her sceptically. She told me again everything would be fine. She was right. It's worked out very well, and we're very glad that she keeps signing the cheques. Thank you very much.